We want this to be as interactive as possible. So, as there aren't many of us anyway, so you might as well, I think we've got room for everyone to join us on the stage, haven't we, Chris? So, we should be all right. If you're not careful, if you don't ask a question, then we'll bring you on stage. Is that a good enough threat? Right, so I'm Tal GP, work in West London, and this is...
I'm Blessings. I'm the head of PCN Strategy and Development in the same patch where Tal works in Hounslow.
And my name's Chris Hilton. I'm the Chief Operating Officer for West London Trust, which is the Community and Mental Health Trust that also covers the area that Tal and Blessings work in.
What are the chances? Does everybody else here work in North West London? Well, so I think what we want to do today is talk about a few little things. So that medicine goes through, healthcare goes through fashions. And at the moment, the fashion is integrated neighbourhood teams. So we're not going to be backslapping, or we're going to happy to challenge each other and stuff. And if we have a big punch up, can you have a big punch up? No, maybe not. But we don't have to agree. And actually, what we want to do is to actually get you guys to contribute and say what you think about, the challenges you're facing, and actually we can maybe between us come up with some answers. But the theme for today is productivity. So Chris has written a paper on productivity, hasn't he, in the BMJ recently? What is it?
What is productivity? So just drawing together the two themes. So there's if you do want to read a paper on this, myself as Chief Operating Officer in a trust and our Chief Medical Officer, Dr. Derek Tracy, spend a bit of time pondering, particularly for mental health and community services, how we measure productivity. In North West London, we have been on a journey, like a lot of systems, trying to evidence that the investment that we've got over the last 3 or 4 years, particularly in mental health, where we've had ring-fenced additional investment through the Mental Health Investment Standard, is actually delivering more than we were delivering in the pre-pandemic period. Now, more in medicine is extremely challenging to define. The finance department got its own methodology for determining whether we're delivering more, because they can count how many times have patients been seen as kind of units of activity that may have been purchased by our commissioner. But of course, in some specialties, seeing a patient a lot probably means that you're not doing the right thing necessarily, or getting the right outcome, or supporting the individual patient and their system and their family to be well, to remain well. And particularly in mental health, I would see a greater intensity of intervention, perhaps as a marker of a failing service, because you really want to promote patient self-support, and we kind of want to make ourselves redundant. We want individuals no longer to require our input. So we hypothesized in this paper a few ways of trying to have this conversation, and it can't, in my view, really be done without clinicians of all disciplines, as well as patients and carers, to kind of try and determine, well, what do we define as more productive? We want people to ultimately get well, and we started to draw upon international themes like the triple, quadruple, quintuple aim from the Institute for Healthcare Improvement as a way of thinking about different domains that we might measure.
Well, we'll come on to the answers in a potential places we could look for solutions to productivity. But how do you, mental health, primary care, are the productivity measures used in the NHS predominantly about orthopaedic operations?
Well, it's probably quite easy to count orthopaedic operations because the operation has happened or hasn't happened.
Yes.
And there are a number of other interventions. Mental health is an example as well. One of our best data sets is in the talking therapies world, where the whole spirit of what was originally called the Improving Access to Psychological Therapy program was about trying to have a high intensity intervention that has measurable baseline and outcome measures. And so they're using baseline and outcome measures for every single patient that passes through that service in a really evidenced way. But it doesn't work for more complex cases. And in primary care, it's really challenging.
Things, any thoughts on productivity, making people work harder and faster? Surely that must improve productivity, right?
Yeah. No, I think definitely there's a case for productivity because obviously, as we were talking, our finance officers want to see results. Otherwise, if you put a business case and you don't say how much you'll achieve, then they're not going to give you the money. So it's very important. I think in primary care, as we're talking, there's some technology which we're looking at, which will improve the productivity of our team. So productivity for me is about efficiency. So at the moment, for example, for the Oz roles that we have, our staff...
People may not know what Oz roles.
Oh, okay. So the additional roles that have been introduced into GP practices like nurse practitioners, physios, paramedics to support GPs. So most of these roles are supposed to improve capacity or increase capacity. But at this point in time, they're seeing patients in sort of 30-minute intervals, and GPs see patients in 10-minute intervals. So there's a degree of inefficiency there. So I see a space for AI technologies like ambient dictation, for example, helping us to be more efficient, increase productivity. When we create that space where GPs can see more patients, then we've got a space as well that we create in the INT world of being proactive because, we're improving sort of the front end of the service. Yeah.
Chris, would you mind? There's a lot of buzzwords, aren't there? We go back a long way when neither of us had grey hair, I think, in those days.
I had some hair.
there is that. I didn't want to say that in public, but Chris used to have a lovely head of hair in ICP days, wasn't it? How long ago was that?
About 15 years, I think.
So the concept of integrated neighbourhood teams is exactly the integrated, sort of us working together. So Care Pilot, it was called. The idea is really not that complicated, right? So all you do is you get people from different clinical and admin backgrounds, stick them in a room, get them to work together, coordinate the care with putting patient in the centre. How hard can that be? Why hasn't it worked? And why hasn't it worked anywhere in the world?
So I would disagree with you about the fact that it hasn't worked anywhere in the world. There is, I think on the surface, trying to do integrated neighbourhood working sounds simple. And ultimately, it's all about relationships. It's all about knowing the individuals who work within your neighbourhood. And the reason that they've designed integrated neighbourhood teams in the UK around populations of about 50,000 is not actually about the number of patients. It's about the kind of number of healthcare professionals that might support a population, which when you get to more than about 100 or 120 staff, you won't know them all to chat over the water cooler or whatever the London equivalent is. So that relationship stuff is really important. So when we worked together a few years ago in Northwest London, it was as part of the Integrated Care Pioneer Programme, which predated STPs, which predated ICSs, which predated ICPs. But it was all about trying to create neighbourhood conversations. And it incentivized trusts like mine and primary care practices and neighbourhoods like yours to get in a room together to discuss complexity. That bit worked really well. And actually, I was a clinician full-time back then, working as a psychiatrist, and I really enjoyed those conversations because my role was in a conversation about diabetes to say, oh, have you thought about their mental health? And actually, by the end of the 12-month period, it was a really much harder conversation because all of my usual suggestions, the GPs I was in the room with were saying, well, before you ask, I've already measured their PHQ-9 for depression. I've already checked that they're not developing dementia. I've already asked them about their compliance. I've already asked them about their drug use. Now what do I do? And that conversation was enriching, really, because it meant that all of us I learned an awful lot about diabetes, but also I think the group was able to think in a much more holistic way about patient care. Why did it not continue? Incentives. So the incentives were there. It was funded as a pilot program, and there was cash available to reimburse my time, reimburse your time. And it was evaluated through the Nuffield Trust and had pretty positive outcomes in terms of reducing non-elective hospital attendances for that population. But then the money dried up and everyone went back to doing what they'd done before. What we now need to crack, and I don't mean this to sound like we're streeting, what we now need to crack is how we change the way we do our main job to function in that way, rather than doing it as a backfilled extra.
So that is exactly the point, isn't it? So if it was that good, I'm just putting it out there, I'll come to you. We'll do the past of two men reminiscing about the olden days, then you can do the future bit. If it's that amazing, Chris, why didn't we carry on anyway? Why, if it resulted in more productive organisations and happier staff, and which I think it did actually, what stopped us doing it?
Good question. I don't fully know the answer, but one hypothesis would be, I think, that we worked our way through a chunk of patients where there was work to be done.
True.
And so, as I described earlier on, I think we'd worked through a lot of the low-hanging fruit's the wrong word, but some of the things where initiatives that we could come up with together to support the patient pathway, we could do them, and that left a lot of the complicated patients that are complicated, that have got multiple factors in their life that were beyond our control. I think the other thing that I would say, and this is links to the digital technology aspect of today, North West London invested a fortune in bringing together data in a really rich data set, which we've still got. We've got the whole systems integrated care database. We've all got, with the appropriate permissions, access to. But in a very NHS way, this brilliant data set was only available electronically if you filled in a form on paper in triplicate and had it signed in paper and ink and sent it to a meeting that only met once a month in order for your IG permissions to be granted. Now, I'm pleased to say that has improved, and a lot more people now have access, and the access rights are all granted electronically. But I think that was a barrier to being able to play with this really rich data set. And, I can see for our borough, I can segment the population by all of their protected characteristics, by practice, by PCN, by the long-term conditions that they have, by the frequency of their utilization of mental health services, of emergency services. This is brilliant. And why anyone didn't think that every clinician in our system should have access to this baffles me, but now we can, and I think we're starting to use it.
You need to to reset your password, honestly, it would take a month, because a real live human being had to do it, and you had to be on NHS Net. So, yeah, a real live one. Blessings. So that's the background history. Yeah. You're leading the INT work now.
Yes, yeah.
What have you learned from that? What are you going to do differently? How are you going to deliver? How are you going to make us all be best mates?
Oh, you can all be best mates. I think we don't need to reinvent the wheel. I think we've got vanguard sites that you're talking about that have already done this kind of work before. I think it's about learning from other places and then replicating what was successful. So I think we've got data now, which is really good, data in our hands. We can do the proactive work. We can do proactive case finding. We can segment our patients. We can work with the core 20-plus population. We need to be in a space. I think what we're lacking more than anything else is states to help us to do this. We are lucky now we have the technology to support us, which when we started, so I started integration around 2016 when the 5-year forward view started. We had to use human interface to try and create interoperability because we didn't have that. Now we've got federated data platforms in some cases. Now we're all on sort of one EPR record that can interface with other digital technology. So I think it's doable. I think it's about attitude. It's about being clear that we've got to innovate and sharing that vision together as a system and then getting everybody to buy into it. It's about us as managers and as leaders, leading from the front. So I think it is doable, yeah.
Really?
Yes.
I like that. You should be a politician. So I'm not sure I'm not sure you're describing the reality
I'll
on the
tell
ground.
you, I'll give you an example.
Go for
So pre-COVID, I worked in an integrated care center where we targeted a population of over 65s. We did case finding. We proactively went to find these patients in their homes, especially patients. So we had case managers to look after these patients who are based in GP practices. So they would actively search for these patients on Rizzic, find them, go and see them, do some preliminary work, bring them into an appointment where we'd have a GP, a pharmacist, a social worker. If, for example, the patient had diabetes, we'd invite a diabetes specialist nurse. So we had the whole care team around that patient. Granted, the appointments were about an hour long, and we were funded very well. So the pilot worked extremely well. However,
I'm not leaving the stage.
The same old thing that happened before, the funding stopped.
But then, is it sustainable? That's the point. So here you're describing 50 people in a room, 1 hour appointment.
Yeah.
Of course, that's not going to be sustainable. Chris, have you got an answer?
So I mean, I'm not going to pretend I've got a magic wand, but I think we're all trying to develop neighbourhood teams because it feels like the right thing to do. It really feels that, getting multiple disciplines around the patient will really help us to provide better care. That's really hard if we're trying to think about productivity, because of course there's something is quite productive about a hospital clinic where you've got an MRI scanner behind you and you can churn through patient after patient in an outpatient setting with the patients doing the moving. And we need to try and define the role of the specialist generalist out in the community that is able to manage most of the stuff that patients bring and a team around them to support them. With your additional roles that have all been added to primary care, where they really add value is where they are substitutional. So if you come saying you've got an evidently musculoskeletal problem, going straight from the receptionist to the musculoskeletal specialist physiotherapist saves the GP an appointment to do something else.
Absolutely. Yeah.
What doesn't work is if you have to go to the GP first, who says, yep, you're right, you have got a musculoskeletal problem, and then you go, because then you've added a step to the pathway. So what we need to do is try to take where safe and where clinically appropriate and where patients agree and are fully aware, take that step out so that we can go direct. But we've done other good work, which then says, well, you know what, I'm an MSK physio.
Yeah.
I'm going to refer straight into some of the interface pathways with trauma and orthopedics because we can work together as the community MSK provider and the primary care extended provider to take more steps out of the pathway where it's safe to do so.
So I'll share a personal story. Think of any questions that you have. We're going to wrap up soon. So I injured my knee. I know it's hard to believe because I look like an athlete and everything. So I went to the GP and they said, oh, we'll refer you to MSK. MSK came 2 months later, 2.5 months later, sent a letter saying, if you don't respond in 7 days, we're going to take you off our list. And they did. And I'm going to go back to the GP and get another referral. So I'm going to just say, Blessings, just the concept of, this is quite a simple concept. So lots of people, MDT type style stuff that we've done to death, and arguably you could say productivity, is it productive, is it not? Does every single person in the room need to be in for every single patient? Or can we do groups of patients? So Sarah is one of our managers. Do you want to share some of the stuff we're doing at PCN level?
Yeah, so kind of the concept that you mentioned about having many clinicians just with one patient, kind of doing the opposite and doing probably one clinician to many patients, testing something like that, which has worked. But having people around, we've had kind of people going around to different stations, so maybe grouping up patients, 6 patients together, working their way around, understanding the different kind of services available, getting like blood pressures checked together rather than individually, getting them to check their own blood pressures, so put them on the table, have a clinical pharmacist there who can talk them through it, and then empowering them to do it themselves. So yeah, some of the different things we've done. Yes, so we've done this in our practice and within our PCN, where we group clinical, non-clinical staff members, so social prescribers, clinical pharmacists, care coordinators, with people that they wouldn't usually work with, about 5 to 6 people, give them a bit of data from their WISIC dashboards, and say, okay, we've got a problem with uptake of cervical screening. Here's the data, have a look at it, spend some time looking at it, and just test things. So do like test and learning cards, and implementing something. You know, sometimes it's just, finding out what is the underlying issue. We thought with cervical screening, we thought it was people were embarrassed, they didn't want to come in, but actually we found out that it's just they didn't have the time. So it was just, spending time with people to look into them.
So is that the answer?
I mean, I think it's fine. I think anything we all try to do is, it's good to do something. But I think if we are targeted, we're more productive. If we are targeted and proactively stop the people that are coming in reactively, I think we then become more productive in the sense that if we equip, in the INT spectrum, we're equipping people with the ability to self-care. So when we proactively find these patients who would not normally perhaps present to GP practices and then come into hospitals when they're iller, the aim of proactive care is making sure we catch them before they become unwell and then become the numbers that are seen on a regular basis. Something like an MSK instance that's happened that will need to be seen. Of course, these things need to be seen, and then you need to have that appointment available that's not being utilized by somebody who, we haven't sort of managed proactively. Yeah. So I think the INTs are available for us to do things that we haven't done before in the past. So we're normally in GP land is about people presenting when they're unwell. The aim of INT work is to provide people with the ability to look after themselves, or those that we haven't actually come or are still festering in, disease, so to speak. We catch them out earlier and we support them. So that's where the difference is. It's in the public health element, I guess. That's what we'd call it.
Chris?
I mean, I guess there's a degree to which the management of this is an art as much as it is a science. And we've both talked about the need to have good data to help understand the populations you're looking for. I was thinking about being mindful of the impact of the interventions that we're changing. So we've been interested in integrated care for a long time. I went to visit a quite well-known provider of integrated healthcare in the States a few years ago, and I saw what was an incredibly efficient clinic where everybody in the clinic was working at the top of their license. Okay. The person at the reception did something that was extending their scope, then there was a nurse extending their scope, and then a physician's assistant extending their scope, and finally at the end of this queue of people you saw the hospitalist who had the whole case presented out in front of them, and you could just kind of draw it all together and go, boom, this is the plan. Very efficient. What terrible patient experience being churned from door to door to door. So we do need to find the sweet spots of making efficiency, but also care provider experience, but also patient experience, because this is about human interaction. So we can use AI, we can use technology, we can proactive case find, but we also have to remember that there is stuff that comes from the interaction. And I was thinking of the provocation you made a minute ago about, do you need all of these clinicians sitting in the room all the time to look at all these cases?
The truth is that when we were
expensive.
All those years ago, when we were doing those MDT meetings, we only needed the psychiatrist for 1 or 2 patients out of 6 or 7.
That's where I disagree with you.
No, everyone.
So
no.
I was waiting for you to
so
if you were designing this to say we're going to have a diabetes meeting, why the hell are you inviting a psychiatrist to a diabetes meeting?
A psychiatrist is the only person who will, if you say you haven't got a problem, he'll say, well, that proves that you have.
Yeah, but why are you inviting a psychiatrist to a diabetes meeting? The reason is 35% of individuals with diabetes have a diagnosable anxiety, depression, or more significant mental health problem.
65% haven't, Chris.
That's true, but the value of the generalists in the room will start to detect which is in which group, but also to try and think about other motivational and psychosocial factors that actually might not be picked up by the other clinicians in the room. So I think there's a value in having some other disciplines in the room together.
But it's a trade-off, right?
It costs. It costs.
Back to the one versus many. If you've got questions, put your hands up. I'm going to go for it, Blessing. Go.
So I think rather than have everybody in the room, you could have a pre-clinic huddle of all the specialists virtually. and you can discuss the patient. Everybody can have their input. We take 30 minutes of a clinician's time. And then we see our 15, 20 patients who we've discussed beforehand and had input from other clinicians. Then the patient essentially can have, input from 30 clinicians or 20 clinicians as required, but see their GP, for instance, who'll be the main clinician.
Hi, I was just going to say, apologies, I actually arrived a little bit late to this because I got caught, but I really wanted to... So I'm actually not from the health sector at all, but I want to be. So I've just taken a couple of days out of work to come here. And I really just wanted to ask, in terms of the way that physical health and mental health is seen in the NHS, is there still a big divide in that? Or have I missed that? Because the way I see things is, obviously it would make a lot of sense to have collaborative care all the time, because those who are suffering with, severe back pain or whatever will also be suffering in their head as well, because it really does affect them. So I was wondering, why is there still a big sort of perceived gap in the way that they're both treated, and is that getting better from a NHS perspective?
Before you answer that, Chris, it's Christmas, and that's your Christmas present.
Oh, thank you very much.
Is mental health the most important thing in the world?
So I think you're right. There is still a gap. There's for the last 15 years or so, there have been various campaigns about there being no health without mental health and wanting parity of esteem for mental health. And we've gone some way at increasing the funding that's going into mental health services. I think the understanding of mental health has gone up a lot, but so has the demand for mental health services. One of the things in the NHS, in terms of how we're structured, a huge amount of mental health is delivered in primary care. And in fact, a psychiatrist once told me that if you don't really want to see mental health patients or mental health problems, become a psychiatrist, because psychiatrist productivity is, you might see, 20 a week, whereas a GP who didn't want to work in psychiatry probably sees 30 a day in their 10-minute slots. So there is a huge amount that goes on in primary care, and that is by its nature integrated. By the time you get into secondary care, we tend to split it. So you split off into specialist physical health pathways or specialist mental health pathways, and we've spent the last 15, 20 years trying to build interfaces back between them. So my background is as a liaison psychiatrist. I work as a psychiatric professional in a general hospital, looking for the place where the physical health patients have mental health needs, or looking after the mental health patients who also have physical health needs. So that's that overlap space. But you're right, there's a hell of a lot more work to do.
Any other questions? I'll come round.
Hello. I'd be super curious, because it's a technology conference, where you do see the opportunity for technology. I happen to found a technology company, but a big believer that it's really not the answer and needs to fit into the human interaction and the workflows that exist. And I'm super curious for what challenges that you've been talking about today you would wish and wave a magic wand that technology could help you achieve some of these things.
Okay. All right. So in primary care, I think what would be a dream for me to see is if patients were to come into the room and we have a piece of technology that has already gone through the patient's list for the GP, for example, and is able to say, you're going to see Mrs. So-and-so coming in, after they've been checked in, this is what they present with, then the GP can actually have some idea of what they're going to be dealing with. So 5-10 minutes, they've got the consultation to a T because they know before the patients come in. The other thing, obviously, which I've spoken about, which increasingly seems to be available, is the dictation, the writing of letters and the consultation as it's happening. I think that's helpful. It helps clinicians to spend more time with the patient and then not worry about the overwhelming paperwork. So that's a dream.
I would.
Apparently, he's built exactly what you've just asked him. So Merry
Okay.
Christmas.
We'll talk.
I mean, I think a lot of the things that we want, you want to, it's more of a shopping list than a wish list in many ways, because some of these products exist, there are some odd anomalies with the technological products that we've got. There is a very famous electronic patient record manufacturer that is used in
Go on, spit it out,
places
Chris.
not very far from here, where I cannot find the search function. So kind of what is the point of the
Is that
electronic
you or
patient
the
record
software?
without being able to search for the records? That seems insane. But I think there are lots of opportunities. Data is important, being able to bring the data from lots of different sources of information, particularly where we extend into social care and education, as well as health, the other determinants of health, is really important. We've started that, but we're not very mature at using it. I think using ways of manipulating that information to help us find rising risk. These tools exist, but we also need to put on the layer of equity onto this to make sure that we're not favoring certain populations over others, and just because your data's not in the system and you've not demanded healthcare or sought healthcare before doesn't mean you wouldn't benefit from it. And then I think there's tools to improve the productivity in the clinic. You've talked about ambient AI recording the records. We've talked summarizing. I mean, psychiatrists will. Some of the reports are pages and pages and pages and pages long, and I know my GP colleagues dutifully file them. But having dutifully filed them, it would also be quite nice if there was a one-paragraph summary of what it said.
There normally is, in all fairness. That is there. I'm going to be slightly controversial. I'm not entirely convinced that technology is the answer, actually, because there's a real, genuinely, I just AI'd this and scribe in 50,000. I don't know. I think we need to go back to basics. I think we need to go. I'm biased, but what we did in our piece is that we want you to go away and do stuff, right? There's no point coming to a conference and just saying, "Oh, AI and all that stuff." And you got to take something away that's home and take something you can change at home. And I think I would argue really strongly, and we said we'd argue a little bit. It's not really a proper argument, but I think it's about your people. I think spending time with those people, one-to-one appraisals and talking to them, understanding what they're good at, what their skills are, without having a bit of software.
The technology might make time for you. If you can save time doing low productivity work, you can then have the conversation time with the patient or with your colleagues.
Exactly.
So that's where I think
Half the time, you have to integrate stuff with stuff that doesn't integrate.
I think that's the problem. So we've got companies that we're using that I could say maybe refuse to integrate with AI, which is not ideal. So when we're commissioning, we need to be thinking of that. No. So the other thing, the other thing which I think would be very important, say for example, in the community, you'd want, as a community clinician, if your patient went into hospital, you'd want a system that would ping you, flag it up to you to say your patient is in hospital. So you can follow the patient in. So you do some kind of reach without, having to wait for just an admissions notification, which can take 2 to 3 days. So we'd want something that would link, for example, with our system one, maybe with Cerner, where as soon as somebody's in a ward, we see a notification. If I'm looking at a patient saying, okay, Mr. So-and-so is in there, I can get my case managers to go in, start having conversations with the hospital. This is how their home environment is, taking community intelligence into the hospital. Then we discharge the patient quicker. So I think with technology, there's a lot we can do if we think about it a bit more creatively.
And if we implement it properly. So too frequently,
How's that working out?
Well,
you don't know where the search button is.
No, it doesn't exist. That's the point. But the implementation is a challenge. If we move from a system where people are used to being able to write on a piece of paper and file it or post it, to a system that only counts your activity if you have to click 25 clicks of the mouse, there is a problem. Yeah. We need to get much better at counting stuff that we're doing in a passive way rather than having to make active choices, so that you've got time then to provide into face-to-face care and interaction.
Perfect. So final words on... We have to be really quick. You guys, final words on failure. How to cope with failure. Before we do...
Is that a psychiatric question? Let's ask this man's question while I think of the answer.
Just a quick question. I've got an engineering background, and the thing that was taught to me in the beginning was if you have a bad data model, nothing really scales from a product perspective. And it sounds like you guys have a real problem with the EHR system, which is the foundation of everything else, and it's not scaling for all these new tools. How do you change that?
Short answers.
Okay.
Well, one of the challenges is that most of our electronic health record systems are off-the-shelf systems, and we do our very best then to try and make them fit for purpose for local practice. A lot of them are designed for either primary care or secondary care, and not both. And so my own organisation, we've adopted almost entirely a primary care module, which comes with compromises for us, but it enables us to...
That's called true integrated care.
Well, is it though? But it allows us to share the information. Doesn't allow us to share the data quite so well, but it certainly allows us to share information. I mean, I think there's a lot of work to do, and some of it requires national and policy levers with big firms that, you know, are bigger than the NHS as a market in some cases.
We don't procure EHRs. They kind of got
Yeah,
things.
NHSC.
Big comment about EHRs.
Yeah, no, I was going to say it's NHSC,
purpose.
so they procure the EHR. So if maybe there's value in lobbying them to do the right thing. So we know there's a federated data platform that they've created, which is good, which means with a click of a button, once it becomes effective, we can log in only once and see various data from primary care, secondary care, and so on. We need to also pull our other partners, social services, at least in our area, mental health, we're all in the same, using the same records. So I think, you know, it's about a sense of will, you know. Yeah, I think if we're willing, if there's a willingness, and as leaders, there's a willingness from us, and we can influence our staff to work.
I'm going to answer your question because I know you need shorter time. You said how dealing with failure. I think the answer has to be perseverance, because the reason that everybody works in healthcare, whether they're in front of a patient or whether they are in a back office role or supporting the technology that supports the clinicians to support the patients, is because we want to get better outcomes for individuals. And I think there is definitely a need to persevere. We will go around this loop many times more, but perseverance is essential.
I think you're right. I think it's a concept that people find hard to embrace. In our innovation labs that we have in our PCN, we tell people you must fail, right? Because if you're not, then you're not trying, and you got to, and people just still, we say this is a safe place, we want you to fail, and people still struggle to kind of make sure that everything is right. And actually, yeah, I think failure is a good thing. And
Yeah,
it's what you do
agreed.
with it.
Agreed. Yeah, we can only get better, isn't it? You pick yourself up, dust yourself off, and keep trying. So perseverance is key. Yeah.
And last word on top tips for success.
Perseverance.
Shared vision. Yeah, and a willingness to kind of, you know, keep at it and not be skeptical.
And for me, it's get out of your office or surgery or ward or whatever and go and talk to somebody that you wouldn't normally talk to. That's integrated care. You know, it might hurt you, but, you know, you have to talk to people like Chris and Blessings, you know, just despite your willingness not to. Anyway, any burning questions or anything? Really quick one then, and then unless it's like Merry Christmas.
So it's a question for Chris and Blessing. So Blessing, with your case management and the multidisciplinary team, what was the aim for that particular study? Was it a study? And then
It was a pilot, and the aim was the specialist generalist model. We wanted, so our case managers were essentially highly skilled nurses who had, who could go and see a very complex patient, and they were based in GP practice. Okay, I'll make it very quick. Yeah, so the idea of the project was to have a resource in the community that knew a patient population very well and would be their key person. So to liaise with, you know, hospitals, mental health services, social services, that kind of thing.
but that's come to an end now.
It's not come to an end. We're having to kind of
Adapt it to make it
adapt
financially
it to make
sustainable.
it financially viable. So we feel like we've watered it down, but, you know, to all intents and purposes, maybe we have, but we've still got a skeleton of it
Thank you.
remaining.
Just one for Chris, I'm really sorry. So I know you're a psychiatrist, and obviously GP practice have a huge issue with mental health and fitting that into their 10-minute slot and that sort of capacity. Is there any space for psychiatry in a GP practice? I know there are mental health nurses and whatnot who work potentially in GP services, but
Yes. I mean, there are lots of models all over the place. I'm happy to talk to you afterwards about primary care mental health. And in the States, there's a very established behavioral health program that uses social workers to do this, integrated fully into the primary care home.
Thank you very much. Thank you all for staying, and a big round of applause for our amazing guests.